this is I've been together with all my teamworks, Dr. Rania, Dr. Wissam, and my dear professor, Dr. Amr Abdallah. We all shared the knowledge and everything in this great in this article. Thank you so much.
Great. Yeah. Also congratulations to you, because I understand this article also awarded as the best article of 2021, which is also a very important thing.
It was very great to know that, and we were all overwhelmed, and it was very exciting.
We as well. Okay, so I'm announcing the connection of Professor Ibrahim Abu Tahun. So I asked Professor Abu Tahun to give the first announcement and greeting to you in Arabic, maybe just some sentence in Arabic. Professor Abu Tahun, go ahead.
Yeah, thank you very much for your introduction. First of all, I'm really happy to meet you and meet our professor, our president, Professor Kam, and also the main author of Dr. Nuha, the first author of this article, which is really a great article. It's time now to move to more sophisticated techniques and diagnosis, especially of the outcome. And MRI, I think, will be a very good step ahead in this direction. If I greet here in Arabic, you will not understand me. It will be only between me and Nuha. So it's better we speak English. Very great day, very great webinar. I hope we will benefit a lot from it. Thank you all.
Okay, now we have Professor Sharif El Zahar as well, and also Professor Sanjay Miglani. Hello, everyone.
Hello.
Professor Sanjay is the head of the educational committee. So Sanjay, we have Professor Noha El Khatib, the author of this precious article. So you go ahead, please, Sanjay.
Hi, welcome Dr. Noha, and thank you, Dr. Nikupar, for inviting me. And we hope to have a healthy discussion today.
Yeah, and also now I can announce that we have Rania with us, another author of this amazing article. Hello, Rania.
Thank you. Good afternoon. Hello, Dr. Nikupar. Thank you for the invitation.
Hello, Dr. Rania.
Hello, hi Noah. How are you?
Fine, thank you. Very nice to be with you all.
Good. This is amazing that we have a platform in Asian Pacific Endodontic Confederation. And we are very happy that actually now the authors, most of the authors and most of these amazing articles publishing in the area of Asian Pacific. So this article coming from Egypt, which is amazing, another part of the Asian Pacific Endodontic Confederation, which is, we should say that congratulations to Professor Kim and to all of the APEC committees, because this is really a proud for all of us. Congratulations to us and to Noha and Rania for their publication. Obviously, we are going to actually ask them to sit in a very, very hot chair now, because we are going to criticize them. We are going to challenge them. Obviously, I'm not going to challenge them at the moment. I'm asking Professor Mahta Fazliab. You know Mahta from the previous discussion. She is the associate professor in Azad University, which is actually one of the very prestigious university in Iran. And Mahta is going to ask her endodontic resident, Dr. Maliha Niksat, to have her presentation for us. So as all of you know, the way that we have our discussion and we have our journal club discussion, which is the 6th APEC Journal Club now we have today, is we have a presentation by one of our postgraduate students as an endodontic resident to practice how to criticize and how to appraise an article, because we know that these days there are a lot of publications and we need to know how to read them, how to criticize them, and how to appraise them critically, which is amazing to do that. And in the presence of the authors, we are very happy because we can easily ask the question directly from them and get the answer quickly for our future work. For our future work, we have this opportunity to know the better methodology and to know the limitation of the previous methodologies as well. So Professor Fazlia, please go ahead. Introduce yourself and your postgraduate student, and then we may be almost ready to start.
Hello, everyone. First of all, I need to send my special thanks to Professor Nikufa for starting this session, and special thanks to my dear and esteemed friend, Professor Noha, for being with us in this afternoon. Thank you. Dr. Nikzad is the third year student of endodontics, and she and almost 4 of her friends have been working on this presentation, and they're learning how to present their article. Thank you. Thanks everyone for being here. First of all, I need to ask Dr. Malihe to just introduce herself and start the share screen.
Okay, Mahta, before you go ahead, it seems that you are in vacation and you're not in the city. It seems like that from your background.
No, I am inside a hotel inside Tehran. I'm I'm attending a congress here. Actually, I have.
Oh my God! Okay, so you are very active. You are very active. Because I have received a lot of message from my colleagues from around the world that they told me this is the summertime and they are in vacation and they cannot attend today. And I said, to be honest, we cannot change this one. And the good thing is this is going to be recorded and we also publish it after the live session that we have now. Okay, Professor Kim, Professor Sanjay, and others, with your permission, I'm going to officially start the session.
Of course. Thank you very much for this organization.
Yeah, please start.
Okay, thank you very much indeed. Okay, Dr. Nikzad, Dr. Malihe Nikzad, now the stage is yours. Please go ahead. You can start your presentation. I may stop you, or any of the participants may stop you, and they ask questions from you or from Rania or Noha about whatever they think is necessary. And also sometimes, okay. All right. Malihe, are you ready? Dr. Nikzad?
Can you hear me?
Yes, please go ahead.
Hello, everyone, and good afternoon from Tehran. Thank you, dear professors, residents, and colleagues for participating in this session of the APEC Journal Club. And thank you, dear Professor Nekufar and Fazia, for organizing this session. Can you see my PowerPoint?
Not yet, not yet. While Maliha is trying to share her presentation to us, I'm going actually to tell you about why we choose this article. Maliha, when you're ready, please go ahead and share and start. I'm just giving some introduction. The reason that we select this article is because you know that these days regenerative endodontics is a very hot topic in the publication, and it is an advanced technique in endodontics. Thinking about regeneration, you can see most of the publication recently are somehow tempting to say something about it. Even speaking about vital pulp therapy, it is nothing except regenerative endodontics or controlled regenerative endodontics. And one of the main things about the outcome of vital pulp treatment, and in particular regenerative endodontics, is about how to evaluate the outcome. And this amazing and innovative work actually is going to help us to find it out. Okay, I think the presentation is going to start. Okay, Maliha, you can go ahead. Dr. Nikzat, we are waiting for you to start. It seems that there is a technical. Okay, please.
The article's topic that we would review
today is quantitative assessment of intracanal regeneration.
Maria, the quality of your voice is not good. You may.
The article.
Maria, we cannot hear you. Sorry, guys, there is a technical problem. Okay.
What about now?
We can hear you very well, but we cannot see your share one.
I have a minor problem with my internet connection. I'm trying to connect with my phone.
Yeah, we can hear you from your phone very well. You may start your talk and then maybe share your presentation afterward.
Yeah. The article's topic is quantitative assessment of intracanal regenerated tissue.
Recording in progress.
After regenerative endodontic procedures in mature teeth using magnetic resonance imaging, a randomized controlled clinical trial that is written by Dr. Nuha Mohammed and Dr. Rania Neumann and their colleagues from Alexandria University, Egypt. As you know, this article is 2021 JOE Award winner. And in the introduction, I'm trying to...
Maria, take your time and share your presentation from your laptop or desktop and use your mobile phone for the voice. Because we can hear you from your mobile phone very well, but we cannot see your shared presentation. In the time of rehearsal, everything was okay, but I'm surprised that now it happened. Yes, we can see you and start speaking now, please.
So in the introduction part, we read about the regenerative endodontics that is focused on the treatment of immature necrotic teeth. And let's see, I try to mute my phone.
Maliha, everything looks okay. Please go ahead.
And that is focused on the treatment of immature necrotic teeth with wide open apex.
Excuse me, Dr. Maliha, you have two devices with two microphones on. Please turn one of them off. You need to mute your laptop if you are presenting with your mobile.
I'm mute with laptop.
Sorry to interrupt, Dr. Nikzat, you need to turn off your laptop speaker.
Yeah.
I mean, the voice of your laptop makes this echo.
So if you're going through with the mobile, turn off that laptop, that's all.
Is it okay now?
خانم دکتر نیکزاد لپتاپ تو صداشو خاموش کن، نه میکروفون نه صدای خروجی.
Okay.
Go ahead. That's not fine. Go ahead.
That allows more stem cells to be recruited to the root canals. Stem cells of the apical papilla that possess regenerative potential are found near the root apices.
Sorry, Malia. Sorry, Malia. You need to have a rest. Please share the presentation again.
Yeah.
With your laptop. Turn off the voice of your laptop and speak from your mobile phone. We cannot see your presentation again. Just share from your laptop.
And now you can see my PowerPoint?
Not yet.
Okay. Okay.
I can see the PowerPoint fine.
Okay, can you see?
Yeah.
All right, okay. Good.
It too.
Yes, great. Thank you. Sorry, guys. Everything looks okay now.
Stem cells of the apical papilla that possess regenerative potential are found near the root apices, and we have found promising results of regeneration in young immature necrotic teeth. Is it paused now? My PowerPoint is paused.
Everything is fine. Go.
I'm trying to share again. And about the type of tissue that is generated, can you see my PowerPoint? I think I have a problem again with my. And about the type of tissue that is generated.
Dr. Malihe, I start broadcasting from my cell phone. You just go through with my cell phone, okay?
Okay.
Dr. Malihe, I start broadcasting from my cell phone. You just go through with my cell phone, okay? Dr. Malihe, Professor Nikufa, do you have my screen?
Yes, we do have, but make it horizontal, please.
Okay, I'm working on it. Malihe, go ahead.
Yes, we do have, but make it horizontal, please.
It is horizontal now. Malihe, go ahead.
So they have been recently suggested to treat necrotic mature permanent teeth with apical periodontitis. And regeneration in mature teeth have encountered more challenges, for example, fewer stem cells, narrower apical foramina for induction of blood and stem cell migration, and difficulty in disinfecting the root canal of a mature teeth. And about the type of tissue that is generated, we can confirm the tissue by histologic analysis, which is invasive and requires tooth extraction. But we have other techniques such as CT and CBCT that cannot assess the success of regenerated vital intracanal tissues. The regenerated tissue may not be true pulp tissue, but it fills the canal and it is a vital tissue and it is advantageous because it can provide reconstruction of the neurovascular system in the root canal and an immunoinflammatory defense mechanism against microbes. So in these slides, I would like to explain a little about the whole process of producing MRI images.
Okay, Malia, can I interrupt you before you go ahead? Please go back to the previous slide if possible.
Yeah.
Mato, please go back to the previous slide. Yes, I'm going to ask actually the authors, which one, whoever prefers to answer my question. I think this is the heart of the introduction of this article, that what type of tissue is generated during the regeneration. And we know that sometimes we call it even revascularization rather than regeneration of the pulp tissue. So true pulp tissue or just vascularization or some sort of sensation, we don't know about it. And obviously you're going now to discuss and say that MRI is going to help us for better understanding of the type of tissue that we are going to regenerate inside the root canal. So the idea of this reconstruction of neurovascular system or other part of the pulp tissue still, I think, is a big question. Can you give us some sort of introduction why you decide to do such a thing? We know that this is a very important question and is still an unanswered question, I would say that. Noha or Rania, please go ahead and give us some idea about why you decide to do such a study.
Dr. Rania, do you want to proceed? Because the idea of MRI was first by Dr. Rania when she was in a conference in Korea, right? So,
yes.
And we researched in Egypt if it was applicable. It took a lot of time to use the MRI machine, but the first idea was from Dr. Rania's. So let Dr. Rania begin this part. Could you please, Dr. Rania?
Okay, that's great. Dr. Rania, before you go ahead, please tell us about that Congress in Korea, because I'm sure Dr. Kim is very keen to know that which conference it was.
Well, it was very interesting. So this was in 2016. It was the IADR General Session in Seoul, South Korea. And it was a wonderful experience for me. And I was lucky to listen to Dr. Nakashima's first talk about the potential use of MRI, where she and her colleagues showed the beginning of the work of the clinical studies that they started to do, you know, with the mobilized dental pulp stem cell populations. And it was the first time that they highlighted this area of using MRI or magnetic resonance in order to assess the vital tissue. At that time, we had been, you know, challenged in the field of regenerative endodontics. So dental pulp tissue regeneration has been a hot topic for a very long time. And the main focus was always cell-based therapeutics. Now with the regenerative endodontics entering the clinic, we are talking about cell homing. And when we started to think about moving from regenerative procedures for immature teeth and going to mature permanent teeth, and actually the first study that was done by Saud et al. Was actually also out of Alexandria University, Egypt. And this was the first documented study, I believe in 2016, where regenerative endodontic procedures had been tried in mature teeth. So his study originally in Alexandria was on immature teeth, and then he started to shift. So he's a graduate actually of, he is from Libya, but he is a graduate of a PhD program at Alexandria University. So the first challenging question was, how would you assess the success of regenerative procedures in mature permanent teeth? Because in immature permanent teeth, of course, we are always looking for, you know, the classical signs of success. So you have resolution of clinical signs and symptoms, and you have radiographic evidence of healing of a periapical lesions. But in immature teeth, you have the additional goal. So as previously shown by the American Association and European Society. So we're looking at also the continued root development, correct? And so you have thickening of the dentinal walls and you have continuation of root development. In mature permanent teeth, we don't have that. So we were always challenged with the question, okay, you have resolution of clinical signs and symptoms, you have healing of periapical tissue. This probably means your disinfection strategy is good, and so it's promoting healing of the periapical tissues, but what's happening inside of the root canal space? So we all know that if you leave a tooth with apical periodontitis with calcium hydroxide medication, intracanal medication for a few months, you see healing, and then you question, like I was going back to Dr. Sheldon Best's presentation, where you're challenging whether to go back and do, the obturation or not. So we were always with colleagues challenged with the fact, why do you want to do it for mature permanent teeth? Why are you saying that you have some sort of regenerated vital tissue? And then, the results of the cold test and electric pulse testing are always controversial. You have some papers that say you have some over 60% response, some over 50% response. So we were looking to say, what would be some evidence that would tell you that you actually have vital tissue, not necessarily pulp-like tissue. We challenged that theory later on. When we began, Noha remembers this, when we wrote, I think in the thesis, so this was part of the PhD thesis by Noha, and we were so excited at the beginning that, well, okay, so we're gonna assess regeneration of pulp-like tissue. It's not that simple. So we can say there is some sort of vital tissue. So again, in the absence of anything that shows continuation of root development, in mature permanent teeth, there is actually no proof of what kind, is there any tissue actually in the root canal space or not? And that was the idea behind, we don't want to go for a study where, for example, we recruit patients who will require extraction of orthodontic, teeth to be extracted for orthodontic teeth, then go for histological assessment, because at the end, it is an invasive technique. And again, it is not clinically applicable. And so that was the idea behind using some technique that could, assess this.
This is amazing. Always, it is very important especially for our young fellows that and also postgraduate students that they are also inside this conference and as participants, to know that the story behind each study. So when you look at that you find it that Rania traveled to Korea for IADR conference, and then some ignition happened, something happened in her brain, and then she actually started speaking with others. This is amazing. Always, when you look at any type of studies, any type of real studies that they publish, that there is also something behind it, something very important behind it. Thank you very much, Rania. That was very, very useful. Thank you very much. Okay, please carry on. Maliha, carry on, please.
Yes, going back to the slide, and about magnetic resonance imaging, MRI images are high quality cross-sectional images of the internal structure of the body using strong magnets, depending on the behavior of hydrogen protons inside the magnetic field. It is accepted as one of the best imaging techniques for soft tissue and vessels rather than hard tissues. Soft dental tissues have high water content and much longer T2 relaxation times. And about the process, we have a strong magnetic field that can affect hydrogen protons inside the body. Depending on the water content of each tissue, we have different amounts of hydrogen protons that can be aligned with the magnetic field. The more hydrogen protons align with the magnetic field, the brighter the images, and vice versa. Aligned with the magnetic field, we have a radio frequency signal that can alter the alignment from a longitudinal to a transverse plane. And these produce a rotating magnetic field that can be detectable by a scanner and can create the magnetic resonance image by a computer. So the relaxation time is time that hydrogen protons return to their original direction or longitudinal. Pathology scan or water image are the result of transverse proton relaxation time or the T2 weighted sequence. So if we have a collection of abnormal fluid in the pathological tissues, we have the longest T2 relaxation time. So these images are useful for detecting infection, hemorrhage, and neoplasm. Magnetic resonance imaging can provide non-invasive diagnosis and monitoring of soft tissue disease without ionizing radiation. Dental MRI has shown its effectiveness in various branches of dentistry, including endodontics. In regenerative endodontics, it is used to assess regeneration of pulp tissue after transplantation of dental pulp stem cells, both in experimental animal models and in patients. In materials and methods.
Sorry.
Okay,
Me,
Maliha,
if I
before
may-
you go ahead, I'm going to stop you. Rania, do you want to add anything to this part? I mean, about the background of MRI and how we
Yes.
can use this application in endodontics? Can we use it as a regular test or
Yes.
something like that? Like CBCT or pre-apical x-rays or not?
Yeah, so Noha highlighted that, you know, like you were saying, Dr. Nekufar, the ignition of the idea, but Noha is the real champion because the idea, it was just an idea. I would like really Noha to talk about all of the challenges, you know, which
Yes.
Tesla, which device, you know, the coils, all of the challenges that she went through in order to customize it to this application, difference between T1 and T2. So please, Noha, you are the expert.
Yes, Noha, please go ahead.
Thank you so much. As you said, as Dr. Rania said, it was a tiny idea, small idea at the beginning. And in Egypt, we first of all researched about where is the MRI machine at first, and we found that it was in the military hospital. You know that, and it was challenging to recruit the patients, the patients in the study, and to allow them to let them inside the hospital. You know, it's a military hospital, so we had some issues, but it took time to go and to allow the patients to enter throughout along all the intervals. Before طبعا knowing that the machine used in this study was a 3 Tesla machine. As you know, the magnetic resonance imaging is a machine that produces a magnetic strength. The unit of the strength is known as Tesla. So of course, logically, 1.5 Tesla and 3 Tesla, by increasing the amount of the Tesla, this means that the image become more pure and the quality become much better, and thus providing more diagnostic, more useful for diagnostic purposes.
Noha, can we translate it? Noha, sorry, can we translate it as resolution? When we are speaking about Tesla, can we somehow translate it as the resolution? Yes. So 3 Tesla means higher resolution, yes, comparing to 1.4.
Yes. In the literature, we have up to 12 Tesla, but 12 Tesla cannot be used, cannot be applied on humans. And I can't remember exactly. There was a test done in vitro. The purity of the image of the tooth structure with the dentine and the dentinal tubule, it was very, very nice, but this was using the 12 Tesla. And the 12 Tesla, it cannot be applied on humans. So the maximum Tesla that could be applied on humans, clinically applied, is the 3 Tesla.
And what about any special device for the mouth or for the jaws? I think we need a special device for that purpose.
Yes. Usually when the patients enter in the closed MRI, if you have a large circle like this is the magnetic field, the main magnet itself. Okay, so as Dr. Maliha said, we have the free protons are excited and then they return back to the original position. The free protons in our body, to be excited, okay, you need 2 things coming from the machine: the strong magnetic field, which is the 3 Tesla, and it's a radio frequency signal. We have a pulse and a detector, a signal detector. We have 2, like an antenna, okay. Coil, when the patient goes inside the machine, okay, you have something known as the head and neck coil. If according to the body part that you're using, we have the chest area, we have the finger area, we have the leg area, the abdominal area. In our condition, we use the head and neck coil. Okay, the head and neck coil is like one of them receiving, producing radio frequency pulse, and the other one receiving the signal from the free protons, as Dr. Maliha said. The idea mainly depend on the amount of water content in our body. That's why the MRI is usually, it measures the soft tissue, or they can diagnose the soft tissue rather than the hard tissue. Unlike the CBCT and the cone beam and the CT, they can assess the hard tissue rather than the soft tissue.
Okay, no, sorry to interrupt you.
If I may
Dr.
ask,
Sharif has a question. Dr. Sharif, please go ahead.
Yeah. I know as for MRI, you need a contrasting medium. Did you use contrasting medium or you didn't use?
No, we didn't use that. First of all, because there's a published article by, I guess, Assaf et al. He used he was able to produce a high quality images, diagnostic images, without using the contrast medium. And for research purposes as well, for the safety of the patients, we preferred not to use the contrast medium because we didn't know what any side effects. Still, we are dealing with a research, not dealing with something, diagnosing something major. Still a research, so that we didn't want to put the patient in a situation that could put him at risk. And beside that, as you said, that Dr. I guess Assaf et al. He produced a very well quality images without the contrast medium. That's why it was not. We didn't.
I believe also Professor Nakashima in her articles they didn't use a contrast agent.
Yes.
And what about the price? Is it cost effective to use this technique, or can we use it as a usual or routine technique in our endodontic armamentarium or not?
No, it's very, very expensive. It's very expensive, and requires, as I said in the article, it requires special hospital. You cannot find it in a clinic, in a private clinic. It must be found in hospitals. It needs a special technician to adjust the parameters that was written in the article. Any movement or any it has many limitations. I usually, if you remember, Dr. Rania, some of the patients if they just moved or swallowed, or sometimes because the environment of the MRI, they have to cool the machine. So the temperature is very, very low inside, and sometimes the patients are a little bit, they shiver from the cold. That's why on the second and the third intervals, they understood and they remembered, and they bring out their jackets and their cold, to feel warm inside, so that they will not shiver, and we have to repeat the parameter all over again.
Oh my God. What about any other side effect on the patient? Is there any side effect like radiation or anything like that?
No. It's very safe. There is no ionizing radiations at all. Even one of the technicians was a pregnant female, and she was able to save and do all the parameters. It's very safe. Just afterwards, they feel a little dizziness or sound, because of the sound of the radio frequency pulse and signal. It just makes a little noise inside their head for just a few minutes, and then it's all gone.
Okay, thank you very much indeed. Mata and Maliha, please carry on. Go ahead. Thank you very much. Okay, please, before you, Viresh, please, you go ahead and ask your question or comment. Hi, Viresh, thanks for joining us. Please unmute yourself and... Yes, Viresh, we can hear you.
And sorry for joining a bit. You can hear me now?
Yes, very well.
Right. First of all, I would really like to congratulate Dr. Noha and Dr. Rania for such an innovative and such a nice study. Right, it's actually a very innovative idea, right? My only question here is, like, since it is very costly, right? So what is the clinical relevance of this study? What is the clinical relevance? Yes, we want to see the regenerated tissue, but do we really need to see them? Do we really need to need them if we can see radiographic changes and everything? Is it very much needed?
So if I understand the question very well, Noha and Rania, it is about the clinical relevance. Can we say that as an applicable technique in everyday clinical part, or it is just for the research?
Noha, would you like to?
I can, Doctor, you can say your point of view, and then I will say mine. Okay.
Okay.
Yeah, both of you, please go ahead.
Yes. I think absolutely, because of the cost and the limitations, like Dr. Noha was saying about, you have to be selective about the patient. Some patients refuse. That might not make it applicable for everyday clinical practice. But I think as we move very rapidly into the future, I am sure that modification of these devices, like what happened from going from CT to CBCT, which is, we can say we routinely use CBCT. So I think this will probably happen in the near future, not only for just regenerative purposes, but for other diagnostic purposes. I think one of the important applications for MRI would be for the early detection. So meaning that we were just discussing the point of if you leave, so why do we do the obturation? We do the obturation to guarantee long-term success. We might have good short-term success, but what about the long-term success? So with the MRI, and as you see from the results in the study, as early as 3 months, we could show signal intensities that were relevantly different from the baseline intensity. So as early as 3 months, you can begin to say that you have started to see some sort of regenerated vital tissue. So the question here would be, perhaps you can make a decision if you've gone for a regenerative procedure in a mature permanent tooth with necrotic pulp and apical periodontitis, and you see within 3 to 6 months with your MRI, for example, you have a checkpoint at 3 months or at 6 months, you see no vital tissue, no signal intensity there, then you will not wait for a 1-year follow-up to say this treatment has probably failed and I must consider to go for another treatment. So from my point of view, this might be one application, is to show early changes or early signs of success / failure. However, to answer the question, honestly, now I don't think it can be considered as a technique that we can routinely apply every day in clinical practice. Of course, Noha, please elaborate.
طبعا يعني beside what Dr. Rania just said, but maybe if any further research is used, the MRI again for research purposes, this could be we can have an evidence base that later on, maybe a few years later, we will know that by that regeneration will provide vital tissue inside the patients in the mature teeth. And now, because based on the studies that were done by using MRI, but of course, due to the cost effective of the machine and the requirements of technicians and being done in a hospital, of course, it will not be. We will stick that it's just for research purposes for now.
Okay, thank you very much, Mahta.
I just have a question. How long did it take to just gain any image from the teeth? How long time was required for this one?
The patient
for each patient.
For each patient, so it was about from 20-25 minutes inside the machine. If the patient stood, was remained still inside. If there was any movement, we had to repeat the parameter all over again.
Okay, thank you.
Okay, Maliha, carry on, please.
Sorry, just to elaborate on this part.
Yes, please.
Of course, this also comes back to what Noah was saying about the 1.5 and the 3 Tesla. So the higher the Tesla, the longer the time it would be required to get the image. So that is another thing. You might have better resolution, but you would have to have the patient sit there for a longer period of time, and of course, cost.
Okay, and what I understand is about the special coil that you put around the head is also used. So you make it just for mandible or maxilla or something like that. So it is not a part of the usual MRI that we can find it everywhere. Am I right?
No, we just use the head and neck coil only. The head and neck coil, okay, and it builds up the entire head and neck region, and then we can extract the part that we want. Just like the CBCT technique.
Okay, so it shows that if I want to say something about this article, I think the main part is the innovative use of MRI. That is the first thing. And second thing, thinking about if any of us wants to repeat such an article, this is a very, very difficult study because you need to have the cooperation of your patient. And most of the time, these patients are very young, and it is very difficult to ask them to stay steady inside the machine, as I understand. So We need again to congratulate these guys because doing this amazing study, very, very difficult methodology. Congratulations. Okay, Maliha, carry on, please.
Yeah, continuing the discussion about the study design. This study is a prospective parallel design randomized controlled clinical trial that followed the consolidated standards of reporting trials guideline.
Mm-hmm.
And about the study aim, we have two major questions here. Does the size of the apical diameter affect the success of regeneration in mature necrotic teeth? And can MRI be used to quantitatively visualize this regenerated tissue in vivo? Inclusion criteria were patients between 20 and 40 years of age, free from systemic diseases, maxillary anterior necrotic mature teeth with single canals with periapical
Maliha, we cannot hear you. Please unmute yourself. I think suddenly your voice is on mute. Please unmute. Maliha, can you hear me? Maliha, we cannot hear you. Please unmute your mobile phone and speak. Somebody must call Maliha to unmute herself. Mahta, can you ask? Maybe you need to call her. Okay, yeah, I think Maliha is now on. Mahta, please share and carry on.
Yeah, I'm sharing.
Yes, Maliha, we can hear you now.
Can you hear me now?
Yes. Okay.
Inclusion criteria were patients between 20 and 14 years of age, free from systemic diseases, maxillary anterior necrotic mature teeth with single canals with periapical photosis and negative response to sensibility testing with no pacemaker, and they were not allergic to medication or antibiotics. And exclusion criteria were mobile teeth with stainless steel wires, brackets, patients with implants. Study groups, teeth randomly divided based on the apical diameter size into two groups. First test group, they were prepared with ProTaper next system until size X3, that is 3007, and control group, they were prepared until size X5, that is 5006. The participant, the radiographic specialist, and the statistician were blinded to the treatment group. Randomization and allocation concealment, each case was represented by a code and a group name. These were then sealed in a sequentially numbered opaque envelope. Upon enrollment of a new case, the inline envelope was chosen and then opened to start the intervention. The participant, the radiographic specialist, and the statistician were blinded to the treatment group. Patient examination was done as you see with details here in this slide. And radiographic examination, they had preoperative digital radiographs to confirm the presence of periapical lesion, as you see in figure 1 and figure 2 for test and control group. And preoperative MRI scan with 3 Tesla machine and head and neck coil to measure the signal intensity of both the involved tooth and its contralateral at the middle and the apical thirds of the root canals. MRI data acquisition, you can see the parameters of the axial T2 weighted images and 3D T2 weighted images here in this slide. and regenerative endodontics procedure.
Okay, Maliha, can I interrupt you again? Noha and Ronnie, I have a question. Speaking about the inclusion criteria, we understand that you just selected the mature apical necrotic pulp tissue. So they are the necrotic pulp tissue that they have mature apical part. That means the first choice of the treatment is conventional root canal treatment. So in terms of ethical issue and ethical approval, how do you manage to make sure that this is the best choice for the patient to do regenerative treatment comparing to conventional treatment in terms of ethical issue? I mean, if you ask me as a patient, I can do a simple root canal treatment for you, and I can almost guarantee that the apical part and apical disease will resolve. How do you manage to ethically give us some reason or justify the ethical issue? You know, I don't want actually to be very offensive about this part, but for me, it is a bit difficult to accept that, okay, I'm going to do every experiment of you in terms of MRI, in terms of regenerative endodontics, in a case that we can do that in a very, very simple way of the treatment. So can you give us some idea about how do you justify the ethical part?
First of all, may I start, Dr. Rania, please?
Of course.
I think before you go to answer, Viresh is going to add something to my comment. Viresh, please. Please
yes,
unmute.
exactly.
Okay, yes, we can hear you. Yes.
Yeah, adding to your sentence, sir, I also wanted to ask you that if I can finish a teeth with a periapical lesion with a root canal and have a good healing, I know that I can just with confidence tell the patient. I noticed that you have enlarged the apical diameter to X3 and X5.
Yes.
Right. So if I choose a normal root canal, means if I compare it to enlarging a root canal apical diameter to X5 50 size, how much it is justified in terms of apical enlargement, that and what after if 3 months we don't see a regeneration, right? Means if we don't see a regeneration, then where do we go? Means exactly what sir was asking, a little bit adding to it.
Yeah, so Viresh is adding something about enlargement of the apical part, and so make it more unethical in his point of view.
No.
So I think
please don't take it otherwise.
Yeah, sorry, Viresh.
You're actually raising all of the issues that we had in mind when putting the rationale and the hypothesis of the study.
Okay, I think Merfam is going also to add something before we go to answer. Merfam, do you want to add something? Please unmute yourself and speak. Dr. Merfam Khoshkhunejad. No? Okay. Rania or Noha, please go ahead and answer this.
Hello, dear Dr. Nekufa and everybody.
Yes, please.
I don't have any question. Thank you very much. It was a mistake.
Okay, because you raised your hand, I think you want to add something. Okay, anybody else? Anybody else wants to put these ladies on the hot chair or not? No more question. Okay, you go.
Do you want to start, Dr. Rania?
As you wish, go ahead.
First of all, most of the patients were asymptomatic at the beginning. They were necrotic. They were searching for necrotic, so that it is unethical that the patient is in pain, and we want to do our research and so on. Second, the exact details of the procedure were fully explained to the patient. Some of them didn't accept it during the recruitment of the patient or during explaining. Some of them did not accept the treatment and they just wanted root canal treatment. And some of them, thank God, they accepted and they wanted to be part of the research. And They were praying with me, with us, that the treatment goes well, and they were. That's why I was trying to do my best to do everything in a perfect way, because they accepted to help me in my research. Regarding, as Dr. Rania said previously, after 3 months, of course, there were every week, every month, there was a call to say that if there was any pre-operative pain, post-operative pain or flare-up. Thank God there was nothing. And as Dr. Rania said, after 3 months from the MRI signals, since there was change in the signal intensity and it became very high signal intensity, indicating that there was the angiogenesis started and the start of the something started to happen inside the canal as a result of this regenerative procedure. That's why we continued to do our process. And if anything did happen, thank God that nothing happened, we would shift to the conventional root canal treatment, but thank God nothing happened. But of course, everything was explained and there was an informed written and consent done.
No, to be honest with you, I'm not convinced yet. So I'm going to ask Professor Abu Tahun and also Professor Kim. I want to appoint you as a member of the ethical committee. If you are a member of ethical committee, are you going to approve this methodology and give permission to these ladies to start their
Can
study?
I say my point of view first?
Yes, please, go and have your defense. And then Professor Abu Tahun, as the head of the ethical committee, is going to give us permission, or maybe just say that no, we cannot do that. Okay, let's see. Let's carry
see
on.
if I convince you. So,
yes.
So this is a debate I have been having for more than 7 years in a clinical perspective, but since 2002 in a research perspective. So I've been having this debate a lot, okay? So I agree with you that this is actually not only a debate with the patients, but it is really a major debate with our fellow colleagues and clinicians. How do you justify this treatment, okay? So first thing that, of course, we take all of the ethical consents, etc., and the ethical review board, like Noha was saying. But let me highlight what the advantages to the patient are. So if we look at the relative evidence that is there, we know that from the evidence that is present, from case series and case reports, that we have resolution of signs and symptoms and we have periapical healing. So we are not going for a treatment that we know can harm the patient. Because very simply speaking, this treatment there is another alternative option after if this treatment fails. So there's always something else we can do. And in the guidelines for regenerative endodontic procedures for immature teeth, there is always, this is where we go for regenerative first, because we know that if it fails, we have another alternative treatment. So this is number one. And we, of course, explain this to the patient. Number two, if we explain to the patient the option that, yes, you will have an inert material filling your tooth, but we know that the fracture resistance and the longevity of survival of your tooth can be affected. Listen, what if we can perform a treatment where you have a vital tissue, where you have the possibility of continued formation of secondary dentin and reparative dentin throughout your life, which will maintain resistance mechanical properties of your tooth? Would you like that? Number two, if you're regenerating a vital tissue, this means that you will have an immunocompetent system. You will have angiogenesis. You will have immune defense in your tissue for a possibility of facing or fighting a future infection. These are some of the reasonings that we tell the patient. Now, the other thing is this study was not only based on this evidence. That's why we actually chose the difference between 0.3 apical diameter and 0.5 apical diameter. We have actually been conducting studies at Alexandria University for more than 7 years. We have actually a previous study where we have shown both in animals, in dogs, and in patients where an apical diameter of 0.35 or less, 0.3 actually from 0.3 to 0.35 is sufficient to allow ingrowth of tissues in a mature necrotic permanent tooth after disinfection and regenerative procedures. So when we decided to go for this study, we already had evidence from a clinical trial and from an animal study that we are not going to be harming the patient. However, why did we choose the apical diameter to go to 0.5? I agree with Dr. Chopra. Maybe 0.5 is a little bit large to say I'm going to revisit. 0.3 is not an issue in a maxillary anterior tooth because you will seldom finish your preparation at the 0.3 apical diameter. But 0.5, I agree. This means you might be unnecessarily performing apical enlargement. The reason was because we didn't have a precedent, randomized, controlled clinical trial published to say that we can go below 0.5. And that's why we actually used, this was one of the objectives of the study, to say you don't need to do the apical enlargement tier 0.5 to get regenerated tissue. Yes, you might find that the results were a little bit better in favor of the larger apical diameter group, but the results were not statistically significant, which means you can safely say you can go for regenerative endodontic procedure in a mature permanent tooth with an apical diameter as small as 0.3 millimeter, which actually, if we think about it, will not really damage the tooth. If we think also of the possibility of formation of new dentinal, so mineralized tissue on the walls. If I may comment on this point, when we published this work, there was the beginning of the talk about intracanal calcification as a, let's say, side effect slash, a problem, coming from regeneration. So if we think about it from a positive point, if you go for regenerative procedure, even if you go for an apical diameter of 0.5 millimeter, and we imagine that you have regenerated vital tissue, where you will have odontoblast-like cells that will hopefully, some sort of phenotype that will be able to deposit mineralized tissue, then you will have thickening of the dentinal wall. So actually the problem that you had by apical enlargement will hopefully be remedied by the new deposition of dentin or dental-like tissue or cementum-like tissue or demineralized tissue that forms. So I hope this answers your question.
Okay, Viresh, please.
Dr. Rania, thank you for such a nice explanation, I really enjoyed the discussion you were having with your patient to convince him for this treatment. Now, as a patient, my last sentence would be that what are the chances of failure? Right.
Yes. So what are the chances?
Obviously, when you will try to convince me, I'll ask. Sorry, please.
No, I understand. So I would just like to add another thing.
What are the chances of failure? What I will not.
Yes. Just add another thing. We've been so.
That I will not say that. What is the second option?
Yes, I understand you. What are the chances of failure? Maybe I will leave Dr. Noha to answer that question, but I have to point out that since we started, performing regenerative endodontic procedures for mature permanent teeth at our university, we have had, so in the previous clinical trial, we had 15 patients, only one patient, I cannot say it was a failure. It failed for the first trial of regenerative endodontic procedure. We tried again and it succeeded. Now I want to tell you that we have another trial. We had another trial, unfortunately not published yet by other colleagues of mine, where regenerative endodontic procedures were performed as a retreatment option. So a retreatment methodology after a failed conventional root canal treatment in cases with large periapical lesions. And amazingly, all of these cases were successful. So this is a much more challenging environment. In the 15 cases that we had, similar to the study by our study, we had no cases that failed over 12 months period out of the 15 cases. The failures that happened that we noted happen early, meaning that the failure would be if a patient did not respond, so the clinical signs and symptoms do not resolve after 2 consecutive applications of intracanal medication. So you would not move forward with the procedure. You would say, no, I would probably shift to a different kind of procedure because it's a very challenging, harsh environment for a regenerative option. So again, coming back to your question, we've actually been trying to always give our patients a documentation for the kind of treatment that was done. So I Noha, of course, had the consent sheets that the patients signed, but we also give a report for the patient, because here in Egypt, it's a very novel treatment. And the problem is if a patient goes to some other doctor outside, he takes a look at the X-ray and he will imagine that this is a pulpotomy. So he will not imagine that there is a regenerative procedure here. And that was one other challenge. How do we guarantee if this patient is not coming back to us, how do we guarantee at least that no one will harm this patient? By the way, he didn't go for a pulpotomy. He doesn't have whatever other kind of, temporary restoration. This is, by the way, a permanent type of restoration.
Okay,
so
Rania, thank you very much. I think that I have received a lot of comments in the chat box, and it seems that everyone is now convinced. Professor Kim, the president, said that Dr. Rania told everything and totally agree with her speech. Ethically, no problem, I think. Thank you very much, Mr. President. Okay, and also he also add in this trial we have second option for the patient and tooth with another clinical technique. We know no pain, no gain, and in the same way, no trial, no finding. That is a very good message from Professor Kim. Professor Kim, maybe you can unmute yourself and give us some more comment about your topic, because I love this. No trial, no finding.
Yes, actually, in my research, I always try to make a new technology, new method for the research. So we don't need to follow the others' previous studies. So this kind of clinical study is very, very, we cannot measure the value. So it's very important clinical trial. And in the future, we may have some new technology following this suggestion, maybe in the near future, in 10 years.
Yes.
So, yeah.
Thank you. And also Dr. Andrabi, Professor Mukhtar said that Dr. Rania has explained everything very well. I totally agree with her. Okay, now the committee is convinced about the ethical part. Professor Ibrahim, do you want to add something at this moment, or can we carry on? Yeah, Professor Ibrahim, please.
Yes, Dr. Rania, I want to tell you something. Dr. Mohammed knows the answer before he asked the question. But he wants to put you on a hot chair as usual, as he used to do. We know that you have fulfilled all the requirements of ethical approval before you started the trial. We know all these things, consent, everything. And of course, you were so convincing. Your answers were very well known and very well approved, I think, by all of us. And as again and again, if I answered your question, I would give the same answer with Dr. Kim. At the end of the trial, we found results, and the results were so beautiful. And this could be a starting point for something in the future, as Dr. Kim said. So even for the purpose of research, we can do that as long as there is no harm to the patient. Okay, we have many concerns. Preparation up to X5, of course, is over enlargement. We know that, all these things. But at the end, we got very good results. From now until the end of this webinar, be careful of Professor Mohammed questions, because he knows everything. I know him. This is his topic. This is his favorite topic. This is why. Thank you very much for your answers.
We are happy to be challenged.
Okay, yes, that is the goal of this discussion. Yes. Okay, Dr. Fateme Baştürk from Turkey, please go ahead and give us your comment. I think Fateme is concerned about the retreatment procedure and regeneration. Okay, Fateme, please.
Actually, right now, we're more convinced about regenerative endodontic treatment to mature permanent teeth. But what I wonder a lot about was what the doctor said earlier. She said they are doing research now, and it's for the patients who are undergoing retreatment. on very large apical lesions. So I was wondering very much about the procedures and the outcomes so far.
Okay, Fatima, I think this is somehow is a bit out of the subject of today's discussion. And because of the time, I keep your question for the end of the session, if you agree, please. Thank you very much. So Maliha, please go ahead, carry on quickly, give us something about the methodology of the regeneration and carry on a bit quicker. Sorry, Fatima, we go back to your question. Maliha,
okay.
please.
Can you hear me?
Yes.
At the first appointment, 2% lidocaine was given as local infiltration after isolation with rubber dam and caries or defective restoration removal, access opening, canal irrigation, determination of working length, and establishment of the glide pad and confirming canal patency was done. Canal instrumentation was done with ProTaper Next file until size X3 and X5, and UltraCal XS calcium hydroxide was used as a dressing up to 2 millimeters short of the radiographic apex. The quality of the calcium hydroxide was assessed radiographically, and teeth were temporized using intermediate restorative material. At second visit, if the patient had signs or symptoms of persistent infection, the disinfection protocol was repeated. Mm-hmm. And at second visit, if there was no sign or symptoms, 3% mepivacaine without vasoconstrictor was given after isolation with rubber dam. Canal was irrigated with 20 millimeters of sodium hypochlorite, 1.5% to remove calcium hydroxide. Complete removal was confirmed by magnification using an endodontic microscope caps. And a final rinse was done with 20 millimeters of EDTA, 17% for about 1 minute. And induction of bleeding by over-instrumenting a precurve K-file size 25 at 2 to 3 millimeters beyond the radiographic apex. The blood was left in the canals for a few minutes to allow clotting, and biodentin was mixed and carefully placed over the blood clot. And they did radiographic assessment for evaluating position and quality of cervical plug material, and they made coronal restoration with light Q resin modified glass ionomer and composite resin restoration. And in this slide, you can see the requirements of regeneration. We need bacteria-free environment, stem cells, growth factor, and scaffold. As you can see, we have different sources of stem cells around human teeth. For example, stem cells from apical papilla and inflammatory progenitor cells. In this study, they have used calcium hydroxide for disinfecting the root canal, biodentin as a calcium silicate-based material for coronal plug, and stem cell from apical papilla, and growth factor that was fossilized in dentin extracted by EDTA, 17%, and blood clot.
Sorry, can I stop you there? I'm sorry.
Yeah.
You see, the general requirements of regenerative endodontic. The general requirements of regenerative endodontic.
Sorry.
Some sound.
Yeah, some microphone maybe. Okay, please, Rania.
Yeah, I would just be so the wonderful diagram that you have here from the Journal of Orthodontics in 2012. This article was published showing the different populations of stem cells in the oral maxillofacial region. But we have to be careful that here we're talking about mature teeth. So mature teeth, we have no scap. Stem cells from the apical papilla are only going to be present in immature teeth. So it's important here that this is not a target population. There are definitely other target populations, such as, if possible, residual dental pulp stem cells, inflamed dental pulp stem cells, inflamed periapical progenitor cells, periodontal ligament cells, stem cells from the systemic circulation, bone marrow mesenchymal stem cells, you know, residues of herpes sheet. So, but not scap. Scap would not be present in a mature tooth. That's just what I want.
Dr. Rania, sorry to interrupt you. I may add something. This slide tries to just give us an overview through all the studies that have been done on regenerative endodontic procedures, and what you have done in your study were just highlighted in red. We just want to just sum up everything.
Yeah, but the question is, in this study, do they use scap? Because in this study, mature tooth was regenerated. So in mature teeth, we don't have scap, or at least the majority of the stem cells comes from the apical part. We don't have a scap anymore when we have mature teeth. The question is that.
And I have seen in some articles that maybe the inflamed periapical progenitor cells may be the source of stem cells in these teeth.
Yes, but not scap. Scap are
not
only
scap,
present.
yes.
Exactly.
So the part that you highlighted, Maliha, in this slide, you should remove scap and just speaking about the other cells that you highlighted.
Yeah, of course.
Everything else
Dr. Rania,
yes, Viresh.
Dr. Rania, you came at the right point. No, I said Dr. Rania came and justified at the right point.
Okay, carry on.
Okay, in follow-up assessment, they had clinical and imaging follow-up assessment at 1, 3, 6, 9, and 12 months. Successful treatment had criteria. First, lack of pulpal pain. Second, no sensitivity to percussion. And third, absence of any new developing sign or symptoms. In EPT, when no sensation was felt at the maximum stimulus of 64, this suggested that the tooth was non-vital. In imaging assessment, they had periapical digital radiographs at 3, 6, 9, and 12 months to assess periapical healing, and MRI signal intensity measurement that was for evaluation of the regenerated pulp-like tissue at 3, 6, and 12 months of follow-up. Signal intensity of the regenerated pulp-like tissue was measured from the cross-sectional view. Application of the region of interest at the middle and apical thirds of the canal of the involved tooth and its normal contralateral tooth for both groups. Quantity of the regenerated tissue was visualized by the coronal reconstruction of the involved teeth from the 3D weighted images. And at this slide, you can see follow-up assessment from cross-sectional or axial view for middle and apical thirds of the canal of the involved tooth with its normal contralateral tooth for test group. As you can see on the left side, baseline MRI signal intensity for both the involved necrotic and normal contralateral teeth at the middle third of the canal and apical third of the canal. And on the right side in E and G images, you can see MRI signal intensity of regenerated tissue after 12 months. And in this slide, you can see the control group.
Hello, Maliha.
And in quantity of the regenerated tissue was visualized by the coronal reconstruction of the involved teeth from the 3D weighted images. At each image, you can see Yellow arrow that shows the hypointense necrotic tissue at the apical third of the canal for related to tooth 21. With blue arrow, you can see the normal pulp tissue in the contralateral tooth. And on the right side, after 12 months of follow-up, with red arrow, you can see regenerated tissue at the middle and apical thirds of the tooth, number 11.
If I may just make a comment here, I'd actually like to invite Dr. Noha, because really she did a magnificent job on trying to develop this technique to do the corona reconstruction. I remember you developed this technique actually more or less from these images. So can you elaborate on that?
First of it was Dr. Wissam. Dr. Wissam, I mean, he was the specialist in this MRI corona reconstruction. Actually, it was his idea. I found it in the Asaf et al. Paper article, and I asked him if I could do this to see it so that we can be able to visualize the regenerated, not just seeing a white spot in an axial view. So he was able to reconstruct this coronal view so that we can be just not only quantitatively assess the regenerated vital pulp-like tissue inside, but also see we can actually see it, the regenerated pulp-like tissue inside. And in this, I just want to elaborate a certain point regarding the MRI that will sum up the idea of MRI. As we said before, that the MRI depends on the soft tissue. It's a soft tissue diagnostic machine. Unlike the CBCT, it's a hard tissue. And as you can see here, if you imagine a CBCT image or a periapical radiograph beside this tooth, you will find that the enamel here in the MRI, the enamel and dentin are black in color, dark in color, while the pulp tissue is white in color. If you imagine an X-ray image, you will find that the pulp space is darker than the enamel and dentin. This is because the amount of water content in the pulp tissue or the pulp-like tissue contains blood vessels, nerves, lymphatic vessels, connective tissue. The amount of water content is more or less large amount, so it have more free protons. These free protons are excited by the magnetic resonance, by the signal of the radio frequency, and then return back to their resting state, producing this beautiful white image, or a large signal intensity or a bright color. If you can see the enamel and dentin, it has very small amount of water inside it. That's why it produces a very low signal intensity, and that's why it is very. This image, I prefer the coronal reconstruction than the axial, because it really provides a very, you can easily imagine what's going on inside, unlike the axial view.
Exactly.
I guess, and it can even explain everything, why in the necrotic tooth, or the tooth that doesn't have enough amount of tissue inside, so it doesn't have enough amount of water content, as you can see in the yellow, the tooth with the yellow arrow. It's not called hypointense, very low signal intensity compared to the vascularized regenerated tissue. The one beside it, with the red arrow, you can see how it's very bright and it contains large amount of water content, producing this bright or high signal intensity.
This looks amazing.
I wish
Congratulations. This is amazing.
Thank you so much.
This is amazing. I really excited when I read your article for the first time. It was really very, very attractive images and very innovative way for evaluating the outcome of regeneration. Fantastic. Congratulations. Very nice.
Thank you so much.
Very nice. Okay, Maliha, carry on, and a bit quicker, please.
Yeah. In statistical analysis, they use IBM SPSS software, analysis of variance, student t-test, and Cochrane test. In results, they had MRI signal intensity and clinical examination. In demographic data, they had 18 necrotic mature maxillary anterior teeth, 14 teeth with asymptomatic apical periodontitis, 4 teeth chronic apical abscess. Patient age range from 20 to 34 years. In MRI signal intensity, after the regeneration in the X3 and X5 groups, the MRI signal intensity in the middle and apical thirds of the canal of the affected teeth increased from its baseline values to reach the highest values at the 3-month follow-up interval. These values then decrease and stabilize at 6 and 12 months to become approximate to the signal intensity recorded for the normal contralateral tooth.
Very nice.
Comparing the MRI signal intensity of the baseline normal contralateral teeth and involved teeth, after 12 months for both the X3 and X5 group, at the middle third of the canals, there was no statistically significant difference between them. Similar findings were found for both groups at the apical thirds of the canals. And you can see the values here in this table. As you see, the values of involved necrotic teeth for both test and control group was lower than normal contralateral teeth in table 2 and table 3. And in this bar chart, comparison between the two study groups regarding MRI signal intensity measurements through the different follow-up periods, A at the middle third of the canal and B at the apical third of the canal. As you can see at the baseline, the values of the contralateral teeth was higher than involved teeth, but at 3 months, it increased to its highest point and then decreased and become stabilized at 12 months and became approximate to the values of baseline of contralateral tooth. And you can see the values here in this table. In clinical examination, Coil test and EPT, the clinical examination results showed no pain, no sensitivity to percussion or swelling in all 18 teeth throughout the follow-up periods. Periapical healing was enhanced in all cases. Regarding the Coil test, there was a gradual increase in the percentage of teeth regaining tooth sensibility throughout the study periods to reach the highest level at 12 months. For the EPT results in both groups, when the readings were registered between 30 and 39 with a tingling sensation, it was considered a positive response, yet delayed, compared with the immediate positive response of the normal contralateral teeth with reading from 0 to 3. The percentage of teeth regaining tooth sensibility using the EPT showed a gradual increase throughout the study periods to reach the highest level at 12 months in the X3 group and in the X5 group. And in this bar chart, regaining of tooth sensibility in both study groups after the 12-month follow-up, A, using the Coil test, and in B, the EPT. As you see at the baseline, all of them responded negative to the sensibility tests, but at 12 months, almost all of them responded positive.
Sorry to interrupt you. Ronia and Noah, I'm a bit concerned about the EPT answer when we fill the coronal part by biodentin. So in the coronal part, we don't have any part of the dentinoblastic process inside the dentin in the coronal part. And when we apply cold or electric pulp tester in the coronal part, how we can transfer the stimulation to the main pulp tissue, even if we accept we have pulp tissue inside the root canal, we don't have pulp tissue in the coronal part. How we describe that, how we can describe, or again, how we can show that this is a real response from the pulp tissue. Rania or Noha, any of you, please.
Dr. Rania.
Okay. I think we knew we were going to be asked this question, and we knew that this was going to be one of the hot things that we were going to be asked. I think there is a lot of speculation about how this happens. How come teeth with a coronal plug material will sense cold or respond to the electric pulp tester? I think Dr. Diogenes just published a paper in 2020, which talks very nicely about the trigeminal neuronal responses and how he is sort of explaining the possibility of how these teeth, the pulp tissue, can respond to the stimuli. This, I think, is based on a very nice work, which I listened to for the first time in Korea in 2016. Again, this was for me a very nice point, talking about how stem cells from the apical papilla can actually respond to cold by increased levels of ATP. Not by the classical hydrodynamic theory, as you were just saying. It is difficult to reach the odontoblast there and have the movement of the fluid so that will stimulate the nerve fibers. So the probability is that there is some sort of stimulation of axonal guidance and stimulation of the trigeminal neuronal response, which results in this sensation to cold. How exactly? Again, it is speculation because there is no evidence from clinical studies. There are some histological studies, very few that have been done, that show that there are neuronal components that have been that can be positively stained with antigen-antibody reactions in the pulp. But the mechanism exactly, I don't think it is known. I do believe that there are some studies that show that periodontal ligament stem cells can undergo neurogenic differentiation. And there is also a nice article about the potential of the NGF and BDNF expressions that come from fossilized dentin. So from the dentin matrix proteins, you have some of them are NGF and BDNF, BDF, which can all contribute to a neurogenic differentiation, which is a possibility also for the periodontal ligament stem cells or other types of mesenchymal stem cells that might be recruited by the cell homing concept. I mean, that's as far.
Okay.
I think.
Yep. That's very good. Very good. Complete. And okay, Noha, please.
Can I just add something?
Yes, please.
2020, Ravnian et al. They concluded a very, very interesting conclusion using the RNA sequence. They compared they concluded that with the human dental pulp stem cells comes in contact with one of the tricalcium silicate cement, whether they did again bidentin and the MTA, they found that when the human dental pulp stem cell comes in contact with the bidentin, it can release up to 6,000 gene expression compared to the MTA that could express about only 1,500 gene expression. These genes expressions are involved not only in odontoblast differentiation and dentinogenesis, they are also involved in the angiogenesis and the neurogenesis. But this was also another interesting thesis. They said that the mechanism of this gene expression could be due to that upon setting of the tricalcium silicate cement, calcium ions are released. The release of calcium ions, this usually regulates the gene expression and maintain the cell homeostasis. And it was found that the amount of calcium ion produced by the bidentin was way more than compared to the MTA. That's why, but another possibility that the bidentin plays a role in the positive response in our cases or in our article, compared to MTA, compared to other studies used MTA.
Okay, thank you very much. And we have a question from Hengame from Canada. Hengame, please go ahead. Hengame, we cannot hear you. We cannot hear you. Yes, try again.
Can you hear me?
Yes.
Can you hear me? Okay. Thank you for the nice paper and nice presentation. I have actually two questions. The first question is that, do you recommend the same data acquisition for MRI for animal studies? I mean, can we increase the Tesla for the animal studies? And my second question is that regarding the apical, master apical file size, do you recommend, regarding, our knowledge, we know that, it has been some reporting that we can have the regenerative endodontic positive response ranging from 0.3 to 1 millimeter of apical sizes according to previous literatures. Now, my question is that, do you recommend to over-instrumentation of the master apical size, I mean F3, F4, or F5, or you just recommend the over-instrumentation of the hand file? And if you don't recommend, I mean, when we enlarge the apical foramen with rotary instrument, then we will have larger apical size and then the other issues. So if you don't recommend that, please explain why. Thank you very much.
Okay, I think we have two questions. First question is about the MRI in animal studies. Can we increase the Tesla to get a better result for better comparison or not? Please answer this question first.
Can I answer, Dr. Rania? But
of course, Dr. Anat, of course.
I guess that this requires the approval from the animal committee. I guess when you work on animals, yes, of course, by increasing the Tesla, you will have a greater, better quality image for diagnostic purposes. But ethically, I don't think by increasing the magnetic field will be kind for these young animals, unless you are talking about extracted mandible. You are not talking about live animals. And of course, live animals you you have to anesthetize them. I don't know. I'm just guessing. I'm just imagining if I have a dog or a king and the MRI image. No, it must be anesthetized. They cannot be awake. I don't know, but this is my
I think you answer very well, because in animals also we have a lot of ethical issues, and also yes, exactly. Yes. It is very difficult. If you increase that to 12 Tesla, then maybe animal cannot cooperate with you, even if they are anesthetized. It may be very, very irritating and stimulating for them as well. We need to do some studies to understand the best way for that. And the second question is about the use of rotary versus hand file, because when we use rotary files, we may increase the apical size more than the size of the file. So which size do you recommend? And I think, Hengame, it is very important to distinguish between mature or immature one, because if you are dealing with mature one, the size is different, and this study shows that there's no difference between the size. So we don't need to increase the size. But when we are speaking about the immature one, yes, in immature one, the size is important because revascularization may happen quicker. This is my first idea about it. But Rania, what do you think about that?
I think just going back to the first question very quickly, I agree with Noha. Of course, definitely anesthesia would be a problem. I think the higher the resolution, you would need definitely to maintain with isoflurane, so inhalational anesthesia, and that could complicate the equipment with the MRI. I would go back to refer to Dr. Nakashima's work, because she is the pioneer on doing the MRI on dogs, so large animals. And I think if I go for an animal study, I would start with whatever they did and follow that, and then see how it's going to be modified. Now, coming to the second question about the rotary instruments, I agree with you 100%. I saw the question of Dr. Bakhtiar here, and I agree that based, of course, on our study and others, we do not need absolutely to increase more than 0.3 millimeter the apical diameter. However, I do believe that since we are talking about regeneration, and there is a very delicate balance between inflammation and regeneration, where we know for a fact that we need that initial inflammatory trigger or response to stimulate the regeneration process. We believe, of course, that the injury that we create triggers the wound healing response. However, how much is too much? So in my personal opinion, I would go for the instrumentation till the radiographic apex, but not use the rotary instrument for inducing the bleeding, because this, in my opinion, will not be a predictable or controlled procedure. And so you might result with too much injury that would go contraindicate your regenerative procedure. And this is just what I, personally believe.
Thank you.
Very nice. Thank you very much, Rania. Rania, I should say that your brain is full of knowledge and literature. You are amazing. You are amazing. Honestly, you have answered to each question by referring directly to the literature.
Thank you
amazing.
very much.
It is very great to see you in this way, and I'm very honored to invite you to this
platform. I was very lucky to have Dr. Rania in my article, and I was very lucky.
She's amazing. She's amazing. Honestly.
Thank you so much.
Well done. Well done.
Honor is mine.
Okay, Mali, we don't have many times, and I think we are going just to the discussion part. However, we already discussed a lot of things, so you may go quicker and just skim this part.
Just about the sex was not considered as a factor. It does not affect the gene expression of mesenchymal stem cells markers. And apical diameter, the selection of 0.3 millimeter apical diameter size in X3 group was based on the fact that the average size of human cells range from 10 to 100 micrometer.
Beautiful slide, by the way.
And other studies also confirm this size 30 or 0.3 millimeter. And they showed that this size can allow tissue ingrowth in animal model. And other reported studies have successfully performed regeneration with an apical diameter of 0.5 millimeter. Hence, 0.5 millimeter for the apical diameter was selected in this study to represent the control group. And file system about Protaper Next, it has shown that its unique design gives it a swaggering motion in canal, which activates the irrigating solution during instrumentation, improves debris removal in a coronal direction, and it has less debris extrusion compared with manual and other rotary systems. And biodentin was selected in this study over mineral trioxide aggregate because it promotes greater cell adherence and viability compared with MTA, good biocompatibility, sealing ability, bioactivity, and does not cause tooth discoloration, and enhance effects on the proliferation of stem cells together with its strong antibacterial property. And they didn't use MTA because it is reported that the high pH of MTA led to early and pronounced calcium deposit compared with biodentin. This may explain the cytotoxic effect of MTA on the cells and thus its less favorable effect. Use of biodentin instead of MTA with its unique composition may have also allowed better conduction of sensibility responses from the regenerated vital tissue.
Yeah, if I just may elaborate on this previous slide, Dr. Maliha, sorry, yes. So I think the main issue that we noticed from previous studies using MTA, honestly, is the incredible discoloration. And really it is drastic discoloration, and whatever we did, we used the dentin bonding, we used, white MTA, we used MTA with zirconium oxide, but unfortunately always discoloration. So really major advantage of biodentin was this, to avoid the discoloration.
Yes, I agree.
And about periapical lesion, cases in this study showed a noticeable decrease in the size of the periapical lesions in both groups after 12 months. The possible explanation may be that first, regeneration seemed to promote the host wound healing process, and second, immune defense mechanism of the regenerated tissues. And in sensibility tests, the results of the present study were inconsistent with the case series by Saud et al. And Nagas et al., who reported negative responses to sensibility tests after 26 months and 16 months of follow-up, respectively, in mature teeth. The responses to cold and the EPT of the involved teeth were delayed compared with the normal contralateral teeth. And this may be explained by the presence of the coronal plug material, and the regenerated vital pulp-like tissue may have an immature innervation system and reflecting the development of a more organized nerve-like tissue. And they use EDTA 17% that allows the release of dentin-derived growth factor and promotes cell proliferation, migration, and odontoblastic differentiation. It may be hypothesized that a similar mechanism may be effectuated by recruited stem cells after the induction of bleeding in mature teeth. And the limitation of sensibility tests, these tests are subjective and do not assess the pulpal blood flow. And histologic examination are a gold standard. But it is destructive and traumatic and requires tooth extraction, and it's time consuming and cannot monitor changes in the same specimen. MRI images are objective, quantitative, and complementary assessment method to sensibility test, and excellent illustration of soft tissue without using ionizing radiation. And for both groups, the MRI signal intensity of the treated teeth was found to be high after 3 months of regeneration. At 3 months, the regenerated tissue was vasculature was partially restored because of angiogenesis after regeneration, thus showing high signal intensity, and decreased significantly throughout the follow-up periods to become equivalent to the normal contralateral teeth after 12 months. And the significant decrease may be caused by development of more organized tissue in the canal, dentin deposition, mineralization, which may decrease vascularization in the canal, thus decreasing the signal intensity, which depends on the amount of water content in the soft tissue. And in the present study, the signal intensity of the involved necrotic teeth at the baseline was hypointense, which is in accordance with Asaf et al., who assessed pulp vitality and detected pulp necrosis after traumatic dental injuries in children. In this study, however, a few necrotic teeth were hyperintense. This could be because of the fact that some inflammatory exudate from the periapical lesion maybe have filled in the canal space. And here, MRI limitations. First, image quality may be reduced by metallic appliances and patient movements, resulting in patient artifact. And the second, MRI examination are expensive, limited to hospitals, and need qualified trained technicians. And induction of blood in mature teeth is very difficult. Opacity of biodentin that was similar to that of the normal dentin. These are other limitations. And in conclusion, the null hypothesis of the present study, which states that there is no difference between a 0.3 millimeter and 0.5 millimeter apical diameter size in the regeneration of pulp-like tissue in mature teeth using MRI assessment, was accepted.
Thank you very much, Maliha. You did a great job for this presentation. I understand that even understanding this article was a great job for you. Congratulations to you. As a part of this journal club, we're asking seniors to give a mark to the presenter or to appraiser, which is Maliha Nikzad. So Maliha, you may unshare your PowerPoint and turn on your video. I'm going to ask Noha, Rania, Professor Ibrahim, and others to give a mark from A to, I don't know, A, B, C, D, E, F, or whatever to Maliha. And Mahta is going to put that in her registration or in her
A for
logo.
Dr. Maliha. A.
Thank you.
Really?
A+.
Oh my God, she's very lucky then.
I have to add that
A+,
she's
Dr.
going to
Maliha.
have a very important exam tomorrow, and
Oh my
she
God.
put she put almost half of her effort on this.
Good luck.
Fantastic,
Good
Maliha.
luck. Excellent
Thank you
job.
very much.
Okay,
Thank
if
you.
we put our hand together for Maliha first.
Excellent job.
Thank you. Thank you.
A+.
Thank you very much, Maliha. And under the stress of technical issues, you manage that very well as well, because this is a part of the job. You are going to become an assistant professor very soon. So you need to practice that. We prepared this platform in educational committee of APEC because of that, because we want our young fellows to become the future lecturer, and you did a great job. Thank you very much. And now it is the time to say a big thank you to Noha and Rania for accepting our invitation and for transferring their knowledge to us. That is fantastic day for me because we actually learned a lot. I personally learned a lot from you all. So I'm going to ask Professor Ibrahim Abu Tahun, the ex-dean or the ex-president of the educational committee, to give us some comment, and then ask Professor Kim, the president of APEC, to end the session. Professor Ibrahim.
First of all, again and again, thank you, Dr. Nikofar. Really, you are the, what can I say, the most important person in this educational committee. Without your efforts, we wouldn't go to these high levels. Secondly, I want to thank Dr. Noha and Dr. Rania from Egypt. You know, all the Arabs love Egypt. Egypt is the soul of the Arab world. So we come here preoccupied. The third, and this is a great study. But for example, when we say the results for vitality following regenerative procedures, 60% is consistent with the results in all studies. But I guess in coming studies, we should rely on more reliable tests. As you mentioned, Dr. Nikofar, electric pulse testing is not reliable. In most of the other studies, they use the CO2 test, which give us more consistent results, that it is more reliable to measure vitality and viability in these situations. But the most important thing to end up with is that such studies are preparing the ground for or let's say to move into more sophisticated, more innovative diagnostic techniques. We are suffering in endo, especially in endo and dentistry generally, and endo, from tests we are now 2 centuries we are using the same tests, the Coil test, the percussion test. I don't know, this is shame on dentistry and shame on endo. We should move to something more objective and more scientific, more what is percussion test and what is Coil test? Nothing. So thank you very much for this, first of all, webinar. It was really, we learned a lot, as you said, especially for the MRI and all these studies. And this will be the start for future studies. Thank you all very much.
Thank you.
Thank you very much, Professor Ibrahim. And before I ask Professor Kim, Viresh is going to add some comment. Viresh, please.
My comment is, again, sorry to barge in, very impressive study, and I would say this is actually a start. You have started a new era, right? It's like you have just directed and produced a movie 10 years ahead of time, right? It's actually a start of new era, and many of the you are kicking many of the endodontist stomach actually by this study. Root canal is gonna stop, retreatment is gonna stop, and many then you will be actually, you should be considered as one of the pioneers of this starting of this thing. So I am really thankful. I got to learn a lot today, and it's a new idea. Now what I would be looking forward to is, I am not very sure, it's just a thing that came to my mind. You use biodentine. What I would be looking towards is some comparison or use of bioceramics. I do not get any evidence on that. I have no evidence on that, on the regeneration effect, right? Yeah. So, but I'm not very sure, but it's just an idea that came to my mind, that we can see an effect of bioceramics. And if there is any chance of collaboration, I would speak on that. This platform, I would take an opportunity that I am always in for it.
Yeah, this is a very important thing, that this network is because we want actually future mutual collaboration with each other. So that is a good idea. Now we know there is a very important center in this prestigious university, Alexandria University. Am I right?
Yes, yes.
Yes. Yeah, that is very important because we use this platform also to introduce different universities to each other, different colleagues from around the world to work with each other. So we know Rania, we know Noha now, so we can collaborate with each other in the future as well. And you know, as Professor Ibrahim said, Egypt or Misr is very important part of the world for us. This is the initiation of the civilization in the world. So now you are also initiate a new era in endodontics. So from the Egypt, we have this new technique, use of MRI for evaluating mature regeneration in mature teeth as well. So there are a lot of innovation. Thank you very much indeed. Okay, thanks all of you. So Professor Kim, the stage is yours for the final talk and end the session. Thank you very much.
No more final talks. So Dr. Ibrahim told us a very nice mention. So that's all. And then final mention is the civilization is from Egypt. Yeah, I know that. And the mature regeneration endodontics is coming from Egypt. I read that. Thank you, everything.
Thank you so much.
Thank you.
Thank you
We
so
put
much.
together our hand for these beautiful authors from Egypt. Thank you very much indeed.
Thank you so
and
much.
goodbye, everybody. Thank you very
Dr.
much, Maliha. Thank you very much, Mahta, and everybody. Thanks
Thank
a
you
lot.
so much for having us. Thank you. Thank you so much. It was an honor. Thank you so much. Thank you.
Okay, looking forward for future work with each other.
Absolutely. Looking forward to it as well. Thank you so much, dear professors. Thank you. Thank you.
Thank you. Goodbye, everybody.
Goodbye.
Bye. Bye.
And see you next month.
Yes.
Hopefully. Bye bye, everyone. Bye.
Bye bye. Thank you.